seminar on digitising social care and how FHIR can help. I'm Mike Anderson. I'm the Technical Standards Lead at the Faculty of Health and Care at the BCS. I'm also the co-chair of the UK FHIR board, and we're joined today by Taffy, who's going to be giving the presentation, and Kelly, who are the two co-chairs of the subgroup that looks after social care in the FHIR board. So we'll be putting the slides and the recording online, and the way it's going to work is that Taffy will talk for about 40 minutes, and then we'll have a Q&A session. So if you want to put questions and comments into the chat, we'll go through those towards the end and pick out the ones that we are of the greatest interest. So without any further delay, I'd like to hand over to Taffy, who will introduce herself and give the webinar. And thank you very much for agreeing to do it, Taffy. Much appreciated.
Thank you, Mike, and good afternoon, everyone. As Mike has said, my name is Taffy Gatawa. I am one of the co-chairs for the FHIR subgroup, social care subgroup, and we report up to the main HL7 UK FHIR board. Our particular remit is really to consider FHIR, its applicability from a social care perspective. And so today I'm going to be doing a bit of a look back exercise looking at the journey to digitising social care. And I will touch on a few highlights along the way and then finish off with considering really the role of FHIR and how that can help in that journey we're all on digitising social care. Okay, so I'm going to cover digitising social care, as I've said, looking at a few highlights. I'll also touch on the Digital Social Care Records Assured Solution Programme, look at some of the successes, such as GP Connect, which is really a programme around bringing GP records to social care. I'll talk about some of the benefits that we're already seeing as reported by care providers, and also from a supplier perspective. And then, as Mike has said, we will hopefully have some time for some questions, comments, before we end the session. Okay, so the journey to digital adoption in social care started about 10 or so years ago. And at the time, we were seeing a lot of fragmentation in terms of solutions that people had, but also who had those solutions. Typically, we were seeing that with more mature, established care providers. But in the main, those were mostly scheduling solutions that providers had. And certainly, if I think back, and those of you who've been working in the sector for some time recognize this, to early care show events, there was certainly a lot more exhibitors selling equipment, so beds, chairs, etc. And over time, we've seen a change to more digital and a range of digital solutions now available, and really a decline of the beds and chairs, compared to 10 years ago. And I think this just highlights the journey that the sector has been on in terms of digital adoption and digital solutions coming to the market. So during that time, we've seen a growing increase in care planning solutions. And this is particularly key as I come to talk about digitising social care and the Digital Social Care Records programme, because those care planning solutions were really key to the delivery of that programme, and then later on other areas that I will cover, such as GP Connect, etc. And then I've talked about the fragmentation we're seeing in terms of adoption, but really I think it's true to say the same was true for the IT suppliers space for social care. Now, as well as my role as co-chair for the social care subgroup, I also work for a supplier who produces a digital social care record. And so we were seeing that as well from a supplier perspective. And what that meant for us as suppliers, as as we identified areas where we felt things could be improved, it was really hard to have those conversations with people at the centre as an individual supplier. We recognised the need for standards. We felt that certain things could be done better for the benefit of the sector, really, but also from an IT supplier perspective. But trying to get any momentum in effecting some of those changes was really difficult as an individual supplier trying to engage with the centre. And so, along with a few of our competitors, we decided to set those competitive differences aside and come together to form a trade association for IT software suppliers. And with three of the other main players in the space, in 2019, we created an organization called CASPA. And CASPA stands for the Care Software Suppliers Association, and that's our trade association for IT suppliers working mostly in social care. So that was formed in 2019, very much with the aim of trying to bring cohesion to the fragmentation, but increasingly we're all recognizing the importance of standards among IT suppliers and therefore by extension how we could support the adoption of standards for care providers. And so CASPA was born, and through that we were able to very early on start to engage and join in interopen hackathons. And this was brilliant for IT suppliers because for the first time, we could come together with competitors or people providing complementary solutions and work together to think about how we could problem solve some of the data sharing challenges we were seeing. But it also opened up the opportunity to start having those conversations with care providers, so our customers, in understanding the data sharing challenges that they had and how we could collaborate to start to address those. So that was a really key step change, really, for how IT supplies and social care were working. And there, very soon after CASPA being formed, which was the March of 2019, we go into 2020 and COVID hit. And what this did was really amplify the case for better cohesion between suppliers, but also for data sharing in health and care. And there was a real urgency to being able to share data, if you remember at the time. And, there was a cry to understand what was happening in social care, how we could overlay that with the picture that we're seeing in NHS to allow those at the centre and policymakers to make the decisions that were needed to really address the challenge of the pandemic in front of us. At the time, the founding members of CASPA had about 30% market share. And so there was immediate agreement amongst them that they would work with NHS Digital to understand the need for the data share and try and stand up the appropriate solution to help with that. But as well as that, we also began conversations with the wider CASPA membership group to assess appetite and capability in terms of, again, standing up the required solution to share that data set. And the idea was that we would bring together some data from social care, aggregate that, and send it in to NHS Digital, who were then having daily meetings with key people at the centre Global Command to really get an understanding of the impact the pandemic was having in social care. Those discussions began in April, and very quickly, by July, we were sharing data. Now, you're probably thinking, well, come on, that's 2 months, that's not very quick at all. But actually, if you consider some of the IG that's required for any kind of data sharing, particularly at the scale that we were talking about, that was pretty impressive. That was pretty quick. So a small data set was agreed for collection in the first instance, bearing in mind this was trying to give some kind of insight as to what was happening where there wasn't any. And so the need for just doing something small, impactful, was really important at the time. And so we agreed a small data set, which essentially would show the location an ID for the provider, and then looking across at how many confirmed cases there were across both the workforce and also the people being supported within that particular service. So suppliers were off, starting to make the necessary changes, development work within their respective solutions to enable those solutions to capture the data. At the same time, conversations were starting with care providers to explain the conversations that we were having with NHS Digital, and obviously gain their support, their consent for one, to collect the data within the system, and then for that data to be rolled upwards and shared with NHS Digital. So lots of activity in that intervening two-month period. And the shape of that was there were letters back and forth to suppliers setting out what they would need to do, confirming the arrangements that were happening at the centre in terms of preparing to publish a data provision notice, etc. And this is an example of one of those letters. We were working with the programme lead for social care, James Pong, at the time. There were further letters in terms of information going to providers, setting out where they could get additional information, the rationale for the data share, and further letters in terms of what we could use in the conversations we were having with suppliers. So lots of activities back and forth, consulting with other people in terms of the IG that was necessary, Secretary of State, etc. And then by July, the data provision notice was issued. And it really made clear, because I think up until then, we hadn't really done anything, certainly that I recall, like this in the context of a pandemic. And so it was important to be really clear about the purpose of the data share, what was in scope, and also just to highlight that there wasn't going to be any personal identifiable information, because there were some concerns around that, and then also set out the onward governance of that data, who had access to it, etc. And this is an extract from that data provision notice, making that clear, the purpose and why this information was key for sharing. It's true to say that I think most people were on board, but I think being able to do things in the right way by going back and getting those data provision notices in place, gaining the consent, etc., just gave the additional assurance across all parties involved in the process. And so that data sharing was in place for, I think the approval was in place for a year, and so we continued to share that data, aggregating the data and sending that through to NHS Digital. And that was seen as a success, really, in terms of sharing data from social care into NHS. And it highlighted, the supplier market, the capability there, but also it kind of underlined for people the art of the possible in terms of opportunities for data sharing between health and care. So CASPA by then was continuing those conversations with NHS Digital, and so we began to explore further opportunities for data share. We spoke to our customers to understand the pain points for them in terms of where they felt there were gaps in data from NHS, and also understanding what was needed for us to be able to bring that NHS data to social care. And one of the things that came up very early on was the need for this governance around data share, security point of view, and also some of the confidentiality elements for social care. And so you may be aware that there is the Data Security and Protection Toolkit, which is a self-assessment that is completed both within the NHS and more broadly now within social care. And that assesses data security across the main 10 key data standards, so around confidentiality, cybersecurity, ability to respond to an incident management, etc., supply chain governance, etc. And so that was considered to be a good way for assessing capability for social care providers, and provided that they could complete the data security and protection toolkit and meet the standards, then that was the gateway, if you like, for that data sharing between social care and health, and essentially would open up things like GP Connect, access to summary care records, MINS proxy, etc. So together with James Palmer at the time, we looked at the opportunity for bringing some of that NHS data into social care. And by far, the area where we felt we would get the most benefit based on feedback from customers, so care providers, was GP records. So providers talked about not knowing when people were discharged from hospital, sometimes for days on end, or not having the key information in terms of what was changed that would have an impact on the care that they were delivering, etc. And so we looked at what was required. There was an assurance process to go through for our IT systems, so the digital social care records, to be able to bring this data in. But there was huge appetite for doing so, just because there had been long-standing conversations with care providers just about some of the challenges not having access to some of this key information presents in the day-to-day delivery of care within social care. So 3 suppliers initially put themselves up forward for assurance for GP Connect. And for GP Connect, there's a range of options that you can have. One of those is the ability just to present a read-only view of the GP patient record. And so that was what we all elected to do. There was an assurance process, but that was by far more simpler compared to maybe looking at a more two-way exchange of information through the structured GP Connect, etc. So we thought that was a good starting point. And certainly when we spoke to customers about the intention to do that, we got the validation that that would be significantly beneficial to have that view of the GP patient record. And so we began on that journey for assurance for GP Connect. And the first supplier went live in 2020, and that was December 2020. And I can remember getting an email from James Palmer saying, "Oh, this is fantastic. Let's make sure that we start the work to do the evaluation so that we can make the case for wider adoption, etc." So this was good. But initially, this was only approved for clinical staff. Now, those of you who've worked in social care know that there isn't that many clinical staff working in social care compared to NHS. So whilst this felt like a win, there was also a bit of that, well, okay, we're not going to get the full bang for the work and certainly the benefit if it is just restricted to clinical staff. And here I'm talking about nurses who might be working in social care, or occupational therapists, etc. Now, from a care home perspective, certainly in the nursing home, you would have some of those clinicians, but certainly when you start to look at community provision, so home care, supported living, those numbers start to dwindle. So it felt like actually there's a missed opportunity here if we can't extend this to the wider social care sector. So we began the discussion to see, well, how can we make this possible? Understanding the concerns from the other side in terms of, confidentiality of information, the governance, etc. And so through CASPA, we started doing some widespread consultation with stakeholders to try and get that agreement for sharing that GP data more widely. And that involved talking to the Information Commissioner's Office to gain their approval. They had to do their own risk assessment as to the appropriateness of having that GP information shared. We're engaged with the National Data Guardian too, whose role really is around looking at what's right for the patient. And they were very much of the view that for direct purposes, it was appropriate to share the GP data, but they came to the table to really think about, okay, well, what's proportionate? Because there was some concern about, well, are we opening up the whole GP patient record? And so there were these discussions about what's proportionate for non-clinical staff. And so we have the British Medical Association there as well, giving their views, their input, and we consulted obviously with the Royal College of General Practitioners. Eventually, 18 months later, we got to a place where we had the approval. We got to a place where we had the approval for some other roles within social care to have some access to that record. So that was great. And that was really good because we immediately started to get, whilst we'd had the approval back in 2020 for clinical staff, actually that meant a very small group of people were accessing those records. And then immediately, once we had that approval, we started to see huge uptake because it meant that certain services just could not have GP Connect, even though they might have been using a system that was enabled with GP Connect that had gone through all of the technical and clinical assurance. By virtue of not having those clinical staff and those services, those providers were just still blind to that GP information for the people that they were supporting. But overnight, once we had that approval, we were able to start working with our customers, supporting them through achieving standards met for DSPT where that wasn't in place, going through the national data sharing agreements, making sure they understood the sort of acceptable use policies. We put additional safeguards in place within our own respective systems, just in terms of managing that access and traceability of that access, etc. Because we were really keen to make sure that those benefits could be realized within social care, whilst providing the assurance to GPs, etc., in terms of the governance around that. So after some time, the NHS Digital, at this point, I think it had transferred to NHS X or something like that. Having realized the benefits of this data sharing, and particularly GP Connect and the feedback that was coming through, the digital social care records assured solution was kind of born through that. At the same time, they had secured some funding to further digitize the sector, 150 million in total. And so there was a real drive, having seen some of the benefits for those providers that had digital solutions. There was a real drive now to really accelerate digital adoption in social care. So there was funding to support care providers procuring an assured solution. And then they put together a program of what that assurance needed to look like in terms of those providing those social care records. The intention really was looking at that care planning side. So not so much the scheduling, where with the operational piece, but really looking at the care planning side. So assessing what was core functionality in terms of things like maybe having an EMA in place or medication recording, care planning, etc. And setting standards for those social care record solutions around that functionality, as well as some additional standards. So they came up with 14 standards in total for that assurance program. And these ranged from data migration standards, so making sure that as care providers adopted digital, the ability to move from one system to another, etc. There was a standard around how that can be supported. There were standards around the information captured within those social care records. So, for example, I think most people will be familiar with the PRSB About Me standard, which is really a standard that enables the person receiving care to have their voice and set out their preferences in terms of how best to support them, how best to communicate with them, their preferences, etc. and as well as things like cyber resilience, business continuity. So it's quite comprehensive, I feel, in terms of the information being captured, and then operational things such as the data migration, business continuity, etc. And the idea was that it wasn't a, you do it once and you're on the list and that's it. But really, from a supplier perspective, it was also a commitment to maintain those standards, keep up to date with those standards. So as those were updated, etc., there was a commitment to make sure that you would be updating your system and the standard accordingly. But it also provided an opportunity to mandate GP Connect as one of those standards. GP Connect was one of those 14 standards. And that was really driven by the feedback, the benefits realization studies that had been done, and just the impact that that was having across the sector. So that became one of the mandatory standards of those 14 for the Assured Solution Programme. So as I said, GP Connect was first introduced back in 2020 when there was still that clinical restriction, and then became mandatory through the DSCR Assured Solution Programme. And so to date, we have 14 digital social care record suppliers live with the GP Connect read-only view, which is fantastic. And that has wide coverage. So I know that the stats for digital adoption, I think, are close to the 80% that was targeted by NHS Digital. And a lot of those people are using those assured solutions, which means that across the sector, those GP records are being shared across those providers. Most social care providers now can see the last 3 encounters from the GP record. So that means if somebody's visited the GP, they can see what was the nature of that consultation, what was discussed, if there's any annotations about changes in medication, for example, or onward care. Providers can readily see that, and where appropriate, make the necessary changes in terms of the care that they are delivering to those people. They can see medications, and that includes current medications, any previous medications that people might have been prescribed, any issues around those medication, contraindications, etc. And again, that helps with them making sure that where that applies, they make the necessary changes to the medication that they are supporting people with. Other things that providers are able to see is information around allergies and adverse reactions, as well as immunizations, which really, I think, when we talk to care providers, they say having access to that medication information, allergies, adverse reactions, has been game-changing for them. And the sort of things that we've heard people talk about are, where previously perhaps they didn't know about certain aspects of people's medical history, or indeed maybe they're supporting 2 people at the same address. I think we had one case where somebody said they've got a father and son who have the same name. So one of them would be, say, I'm going to pick on Mike because I can see Mike Jr. But sometimes when the medications are updated or prescriptions are issued, they only just have the first and last name without the Jr. And often the provider has to try and work out whose medication it is, etc. So there's been lots of positive feedback just in terms of reducing avoidable harm by having that access to that information. And then as well, from a practical point of view, just the time saving, both for GPs, who perhaps then would be answering queries from care providers, putting together letters, etc., but also from the social care staff who, I think one provider said they spend 3 days a week back and forth on the phone, trying to get information from the GP. So that's an immediate saving. But it also means that's a member of staff who's not on the phone, who actually can then use that time in support of direct care for people. So time saving on both sides and benefits on both sides. Providers say they're better informed on health concerns of the people that they support. And it's really helping to increase the collaboration between suppliers and care providers. And one of the things that's been really interesting is now that people have got this data in their hands, they're like, well, what else can I have? Can I get information of when my patient goes into hospital and when they're likely to come out and what we might need to change? Because if we know what's going to change when they come out, we can start to prepare for that. And then they have a good experience, or there's no delays in implementing those changes at the expense of the person who's at the heart of the care. So that's been really good for suppliers and care providers, because I think now that we've kind of opened those floodgates for data sharing, we can't close that. And I think people now understand the benefit and people want to do more. And crucially, I think we have set out the sort of blueprint for doing that and assured people where there were concerns around information governance in social care, that we can put the necessary guardrails in place to make sure that those concerns are also addressed. And so, as we've continued on that journey for digitizing and data sharing, a key thing has come out of all of this is developing an interoperability platform for social care. And really, this is looking at how can we extend the current data sharing that's in place such that we can have data sharing between social care entities, but also data sharing between social care and health. So expand that even more. And so there is some funding that's been put in place, and actually there is now a confirmed delivery partner for the social care interoperability platform, and that was announced just in the last couple of weeks. And so a lot of providers are now waiting to see how that works, starts to pick up pace. The use cases that have been put forward, I think, are now going through just revalidation. But the things that we can look forward to in the first instance would be some work around access care information for care planning, more integration with GP records, and then looking at data sharing to support transitions in care, and also, as I said, sharing records between providers, which, believe it or not, currently doesn't happen. So being able to support those transition, if somebody's coming from home care into residential and back again, there isn't that seamless sharing of information currently. And the hope is that this will provide that opportunity to do that. With providers now familiar with data sharing, suppliers having worked with standards and done some work around this, we feel that the market is well placed to really seize this opportunity. So we're all watching and waiting to see how this takes shapes. Currently, there is an intention to have an MVP by March of next year, so very soon. Hopefully, we should have something in place for that. Now, I've talked a lot about the standards that suppliers had to implement, which by extension means the care providers are collecting data in a structured way, in a standardized way as well. And I think with the ambition of SCIP, there is a real opportunity for FHIR to support that. So FHIR is the standard that enables the exchange of information between systems. As Mike has already said, there is a UK FHIR board that meets and considers this for UK, and we're looking at this from a social care perspective. And there are already some suppliers within social care who have started to look at FHIR resources and implementing those and getting their systems FHIR ready. And I think with the ambition of SCIP, there's a real opportunity. There's a data set that's been defined for being moved around through SCIP, which is the minimum operational data set, often referred to as the MODS. And as part of that development, they engaged with key people in relation to FHIR to ensure that as suppliers implement that data set, that can also be moved around using the FHIR standards. And so really, it's a real opportunity for us to, as we move forward with SCIP, to look at greater adoption of FHIR across social care, and the MODS provides that opportunity. It also means that where people are working internationally, FHIR is an internationally recognized standard, then there's the ability to share data both internationally as well. Okay, I think I am at the end. So thank you very much for your time. Thank you for listening. We can now open up to questions.
Excellent. Thank you very much indeed, Taffy. That was absolutely excellent. I have to say that my background is more on the acute side, and that was very informative from my perspective, and I hope other people who are from that area also found it informative. You're getting quite a few hand claps if you're not seeing them, Taffy. Okay.
Would you like
So
me to drop
we
the share, Mike?
sorry?
Would you like me to drop the screen share?
It's up to you, whatever you like. Yeah, so yeah, you can probably see the hands clapping at the moment. So we've got a few questions in the chat. Charlie, do you want to kick off with yours and then work backwards? Would that be okay?
Yep, I can do that. The first one was really just to ask a bit of background in terms of that GP Connect existing interoperability. How widespread is that? I mean, you say it's 14 suppliers, but is that kind of 20% or 60% of people receiving social care that are covered by that? And if I went into a care home, how likely is it that?
I think it's as close to the 80%, Charlie.
All right,
So
that's really
it's
impressive.
been really good because a lot of these suppliers, these care providers have all adopted the assured solutions. So I was keen, I made sure to check last night. Yeah, so it's pretty good. And I know that there's some suppliers who are now starting to consider the structured GP Connect, and thinking about the assurance there as well, because they would need to undertake the assurance process before they can bring that into the system. And that's all based on the feedback that's coming from the care providers ultimately.
Right, excellent. And then there's a question from Steve Harris on how customizable are these social care record systems. So are they using fixed data models, or are they using a kind of a templating and a journal style of data architecture?
I think most are quite, fairly customizable. So if I think of our own solution, we offer quite a fair amount of customization as well as templates. The idea being that where you have a new entrant into the market, so a new care provider perhaps, we can offer some of those templated outcomes and things so that they can just get on that digital journey quite quickly. But what we see is as providers take on a range of services and become more complex, sometimes they want to have that flexibility, because it's not uncommon, particularly in home care, where you might have somebody who, as well as doing your sort of standard domiciliary care, they might also have a children's service or complex care. And so that flexibility within the system is really helpful. But a lot of them are customizable.
Excellent. And then just working back, Iraj, I'm not sure if I've got your name right, or whether that's, so what happens if third-party agencies recommended unwanted equipment for patients, and what are the ethics and policies to handle on that? If your company exposes information shared companies when implementing the system. Raj, do you want to come off mute and just say what that question is there?
Can you hear me?
Yes, indeed. Yeah.
Yeah. The thing is, I'm asking about what happened if it is the company exposing unwanted data, like the other companies recommended unwanted equipment, for the high value equipment for that customers, and whatever the things can be happen on that. So that's what I need to ask about that. Did you get what I said on that?
I'm not sure I fully understand. Are you asking about
No,
the information governance or
no, not a,
equipment? I'm not sure I understand.
no, not a governance thing about that. What happen if it is like a when the you are recommending if you are getting the sharing information with the other parties like a third party agencies or whatever the things on that, right?
So I think sorry to interrupt, but I think it's you're partly asking about third-party suppliers of equipment and so on, and I don't know, Taffy, to what extent equipment supplies in social care are held in the systems that CASPA providers supply. And it might be easier to take this offline, actually, but if you've got any quick thoughts.
Equipment supplies. So most of the CASPA members are providing digital solutions. So that, and that's solution agnostic. So it might be an EMA solution, or a digital social records solution, as I've explained, or it could be a roster system. In the main, we don't have, I suppose equipment could be maybe something like, I'm thinking of, we've got a member who provides equipment that enables taking vital signs, so the blue box. But effectively, it's the software, and that integrates with digital social care records. And so something like that would be the care provider would procure that blue box, and then that data would feed into a digital social care records. So again, all of that, in terms of, if I've understood you correctly, is very much driven by the care provider, who ultimately is the data controller. So they, for seamless transfer of information, then they would want the data captured through equipment like the one I've referenced to all populate the digital social care record. And, so that means they will be able to see vital signs that have been taken and then look at that within the context of the overall care planning in a digital social care record. I hope that addresses the question, but I'm very happy to consider that outside the meeting and just make sure I've understood what you're asking, and I can come back with a more informed answer if that doesn't address your question just now.
And then just to sort of follow on, to take another question, which is just a clarification on the roles that are given access to clinical data beyond the clinical staff. So you said that access was extended. What roles within the care home or within the...
So there is two access levels. So there's the clinician's access, so for nurses, any clinical staff. So they have, I guess, the view of the GP record as is. And then the slimmed down version of that access is the 4 categories that I've described. But that is given to, senior care workers, care manager, so effectively the registered manager in an organization, who isn't typically always a clinician, but would be somebody senior who oversees the care. So that includes making all of the care assessments, formulating the care plans, either in the context of the care agency, care home, or within the context of a multidisciplinary team. So they would have access to those 3 sections of the GP patient record, as I've outlined.
So it wouldn't be every single care worker. It wouldn't be
no, there
everyone who comes to your house.
There are some defined roles, which are typically those senior care staff who have responsibility for care formulation assessments, etc., that have those. So we have to make sure we check the roles, and it's only those that then have that slimmed down view if they're not clinicians.
That's great. And there's a couple of comments from Dylan Roberts. I don't know if you want to come on and just talk about that, Dylan. There's good questions about how the access to acute care works.
I know I was just going to say that the two-way data coming from social care systems is extremely valuable to the NHS colleagues, especially even small amounts of data such as what is available can really help with speeding up discharge. So just to make that point. And the other point was the importance around standardizing the semantics or the terminologies you use in when you're recording data is really important in training people around that. And I appreciate, I think Kelly might have put something in the chat, which is access to the terminology, which is, again, helps to answer that question. But it's making sure that these are all things which, are, in my opinion, are really important to success in these type of projects, not just providing the connector. So more a comment than a question.
Thank you.
And I guess the supporting question around that would be, what is happening around, or where do you see that interoperability going? Because at the moment, presumably with GP Connect, that's on-demand access to the GP record, which is different to what would be required if you're doing transfers to and from hospital or other use cases.
Yeah. I think there's a willingness, certainly from the supplier market. There is a willingness for that. I think SCIP provides an opportunity for greater sharing and exchange of information between health and social care. So that's potentially exciting to see that project be realized. And certainly at a local level, there is activity happening, particularly around getting notifications when somebody's about to leave hospital, following if somebody's been conveyed into hospital, for example, getting a notification that they're fit to be discharged. And that allows care providers to start to prepare for any changes in that care when they come out. So I think there's a combination of things happening at a local level, but certainly I think SCIP provides that opportunity in terms of something more national.
That's great. And Will, do you want to come in? I see you've got your hand raised.
Yes, can you hear me okay? Because
Yeah.
Zoom does not like NHS laptops, so apologise for that. So yeah, just jumping in because SCIP, I was only able to join partway through, so apologies for that. But I'm the product manager for SCIP within NHS England, so it's just good to take the opportunity really just to thank you for this session, but also to say a bit of a plug for we're going through discovery currently, and some of you may have already received an email from Synonetics around getting involved in the user research side, because we want to get as many voices from across the sector and especially in the digital realm as possible. So if you feel like you want to be part of that, then please do engage with that process. And if you feel like you haven't been engaged with and you want to, then please do reach out to me. I'm happy to kind of get you involved in that. So apologies for the shameless plug, but felt relevant.
It's great to have you on the call, Will, and good to hear of that work happening. I think we would really like to extend an invite for you to come along to the Social Care FHIR subgroup and chat to us a little bit more about that work. We'd be very keen to hear that. I'm sure Kelly will agree.
Sounds awesome. I'm more than happy to do that.
Brilliant.
And then there's another question here from Andrew Newman around work to define the data that's appropriate to share, and is the need for access to either full patient record or a summary. So I guess that's sort of going beyond just those 4 categories of data.
Are we talking still GP Connect, or are we talking about the minimum operational data set? Because that data set has already been defined, and providers can now go through, I guess, the conformance assessment for the minimum operational data set, which is the data set that's intended to be exchanged through the SCIP. Is that what you were referring to, Andrew?
So I think you've kind of answered my question earlier when you were talking about the roles that you have. I guess from a kind of trust and data governance perspective, I'd be interested to know if you've understood the types of data each of those roles have access to. And if you've got that documented somewhere, that'd be really useful.
How do you mean the types of data?
So as an example, we're doing some work with case management systems at the moment, and we had a presentation from one system provider who had integrated the patient record into their case management system and had set up a process so that social workers got notified every time there was a change in a prescription, and they could see all of that data. And I think the question I came out of that was, do they need to see all of that data, or is there a data minimization question here? I think has there been very much thought given to the data people need to do their jobs, or is it just a case of giving people access to everything so they can pick and choose the data they need? Does that make sense?
I think it does. And so the 4 categories was, I guess, the minimization exercise that was done in terms of understanding the full scope of the GP patient record, and then almost defining what was the minimum that people needed to do their job safely and ultimately, for the benefit of the person whose data it is. So that's those 4 categories for non-clinical staff that's been identified. If what you're asking is within those categories, do we have a sense of what it is they're seeing? I guess that depends on what's recorded within, those records, and how comprehensive or not they are when people access it. We know from, so we report upwards to NHS England on I think it's quarterly. We report upwards quarterly, and there we let them know uptake. So has there been an increase in providers actually going live with GP Connect? And then we further break down that data to say how many clinical versus non-clinical staff are accessing that data, and the coverage in terms of ultimately people receiving care. But what we know from those stats is that by far, looking at people's medication and the most recent encounters with the GP are the most accessed parts of the record. And people tell us that they do that if they've got somebody new coming into a service. Often that helps with things like medication reconciliation, or getting a full picture when they do that initial needs assessment before they start to formulate the care plans. So by far, those areas are the most accessed parts of the record. And what that says to me is that that validation exercise was absolutely correct in terms of identifying the areas that people need to do their job. I hope that answers your question, Andrew.
That's really useful. Thank you.
Kelly, do you want to come in briefly, and then we'll need to wrap up because we're getting towards the end of the...
Yeah, for sure. The first thing is, Will, it would be absolutely amazing to connect much more closely with your project. We've been waiting for a number of years now to be able to go further, faster, and we're all at the ready to provide all assistance. So please, if you would like to come to our group, then do. And Alison Taylor, it's very good to see you on this call as well, because, certainly a lot of the hard graft that has gone in over a number of years now, particularly, through metadata works and all the rest of you. So it looks like it's coming to fruition. So the first thing is well done. And the second thing is we really want to provide assistance, and we're in a position to help you out. So come and get on board.
Well, that's a very good message for us now to hand back to Mike to wrap up the session.
Okay. All right. Well, thanks very much for helping out with that, Charlie. Much appreciated. I think just to say briefly, this is one of several talks we're planning to have because we are very keen to see FHIR and social care digitisation progressing further as soon as possible. There's an awful lot of time and money spent on digitising hospitals and GP and acute care, but we need to do some catching up in the social care space. So if you're on this call and you're interested in getting involved with the FHIR board's subgroup on social care, please get in touch with us. If you're interested in giving a webinar on anything that you're doing in social care digitisation and FHIR in particular, we'd be very happy to hear from you. We're hoping to have something from Wales and possibly other people as well in the not too distant future. And we're hoping to have a webinar on mods this year from Adam Millward. So yes, we're trying to advance the cause basically. So it just leaves what we need to do now is just wrap up. I'd just like to say a huge thanks to Taffy for what I thought was an excellent presentation, really informative, and I think it's raised a lot of interesting questions. So thanks very much again to Taffy, and we'll let you know about
listen.
and we'll let you know in due course about when our next webinar is. But as I say, I hope that will be on mods, and I hope it will be this year. So thanks again, and have a good afternoon. And Taffy, if you just want to hang on for a moment or two, and Kelly as well, while everybody else leaves, that'd be great.